So, hello everyone. I wanted to talk to you today about case area targeted interventions for cholera response. We call them CATI commonly. It's an operational study developed by Epicenter. So this all started with this observation that cholera cases come clustered, which means that the closer you live to a recently reported cholera case, the higher your risk to contract cholera is, which has been shown in different ways, but this is one paper that showed it. And this can be used as a rationale to justify targeted interventions around in the area of recently reported cases. So CATI, what is it? It's a multi-pillar intervention package within the first hundreds of meters around cholera cases, around freshly reported cholera cases, within just days from the reporting of the case. It's not a new idea. It's similar to interventions that have been done against polio or against smallpox or Ebola. And so there is an MSF CATI package that has been defined throughout this project. It includes a single dose of oral cholera vaccine, a hygiene kit containing soap, water purification tablets, a hand washing station, and a water container. It includes antibiotic chemoprophylaxis only for the people living in the households really the closest to the case, and hygiene promotion. There is a rationale behind all of this of the study I'm presenting. CATI has been implemented by different actors in different ways. Not always with vaccination, but it is thought that adding vaccination to CATI is going to have a larger and a more long-term effect. There is a scoping review of the current evidence done by my colleague Ruan, which identified some limitations also, showing that CATI with vaccination has actually never been evaluated, that since the cholera case definition is very wide, which means that it's difficult to know if the cases in the studies were all cholera or not. On most of these studies were done with retrospective operational data that have their limitations, as you all know. So currently, CATI with vaccination is not part of any recommendations either by the WHO or national, but it's part of or similar approaches or multi-pillar approaches are part of the cholera research roadmap by the Global Task Force for Cholera Control. Yes, so this all makes that the goal of the MSF and Epicenter CATI project are first to define a way how to implement CATI for MSF and to make it possible in different countries, to generate evidence around CATI with this study and with the results to guide future policies. For this, Epicenter, together with some collaborators from London School, developed a generic study protocol. It's a prospective operational design that can actually adapt to different setups of doing CATI, meaning different radiuses around cases or different intervention packages. The primary objective is to evaluate the effectiveness of CATI in reducing incidence of RDT-positive cholera. RDT are rapid diagnostic tests. They're here to address this lack of being sure if it's a cholera case or not. So we test the cases actually, and our outcome is the number of secondary cases within the zone where CATI was done, within each ring of CATI. And then we have secondary outcomes. Some of them are the population-based coverage of the CATI and the resources and costs. The sample size of this whole study is 100 rings, and everything has all the ERB all the necessary approvals. It has started in the DRC, is hopefully soon starting in Cameroon, and possibly also in Niger and Zimbabwe. More than just the study, Epicenter, we also developed a tool on an Android tablet that helps the CATI teams to know which household is part of the CATI ring and which household is not part of the ring, as you can see in the picture. Again, yes. From now on, I'm going to talk about the implementation in the DRC, which started already. So in the DRC, we have a number of potential sites by different operational centers of MSF where they want to do CATI if cholera is to happen there. And in 2 of these places, both of them in North Kivu, the CATI intervention and our study started already. This is in Goma, North Kivu, and in Masisi, North Kivu. Okay, so first results of the study. These are really super fresh. So I made those analysis on Monday, I think. So there is 3 sites. 2 of them are in Goma. 1 is in Masisi, going from very urban, very dense to very rural. And you can see also that the ring, the radius that was chosen for the different places, it depends on that population density because of logistic constraints of the number of people you can target. Overall, about 20 CATI rings are either ongoing or have been completed. They contain an average of 85 households, 470 people in one ring. And the administrative coverage of the vaccine is 77%, so which is quite good. There is few refusals, and crucial, the delays from the onset of the symptoms of the primary case that defines the ring to start of the CATI is 2.5 days, and the average delay from symptoms onset to the vaccination is 4.2 days. Okay, and in terms of outcomes, so far we only have 2 secondary cases reported in all rings together, but note that in many of these rings, the follow-up period of 30 days is not yet over. Okay, again, okay. Now I'm going to talk a little bit about the coverage survey. This is even more recent and more preliminary than the previous results. So we do the coverage survey in 30 households in every ring, 21 days after the presentation of the primary case. It has been completed in 8 rings so far, and as you can see on the right in the table, the total number of surveyed households is somewhat over 200. We have almost 100% of households who report to have received our hygiene kit, but only about 30% of households have been able to show us 21 days after that they still have the water container that was distributed, and only 16% still have the hand washing station, or still could show the hand washing station to the surveyors. The soap is there in most places. Water treatment tablets are there in 90% of the households almost, but they were not used because the safe residual chlorine levels in the water that was stored at the households for drinking is only safe, high enough to be safely drinkable in 15% of the household. Okay, so on the wash, this is I produced these figures 2 days ago, I think, so we haven't really dug into the details of why this is like this, but that's definitely something we're going to do in the next days. I can say that the coverage of the first dose of vaccine is much better than what we saw with the wash interventions. And also something interesting is that the coverage of the vaccine from previous vaccination campaigns that were in 2019 is, according to this coverage survey, at least very low in the CATI rings specifically. Let's go on. I'm already concluding. So the study has been running without any major issues in 3 sites so far for the last 2 months and 3 weeks in 1 site. The recruitment of new primary cases in Goma is a little slower than expected, but it's still fine. It is indeed possible to quickly implement CATI in response to cholera cases. So you have seen that our delays to response are really good. So that's very positive. And even in rural settings where you have to go by motorbike from one place to another, the coverage of the intervention is good, but the uptake of the WASH interventions is low so far. Reasons are to be investigated. We have no results on effectiveness yet, but it's promising since so far we see very few secondary cases. We know that cholera is on the rise in several places around the DRC, also sites that have been selected for CATI. But at the moment, it's difficult for us to start the study in different sites at the same time, so we're kind of have a limitation by supervision that we're addressing at the moment. With this, thank you very much for listening to me. Thanks to my team in the DRC who's running all this. Thanks to Ruan, who helped a lot developing the study, and to all the MSF teams who do the CATI in the field, all the ministries of health, and of course all the other co-investigators. So thanks a lot to everyone.